Dr. Yoganathan. I know I'm
Hi,
butchering
Sean.
it. You go by, is it Pran? How do you say that?
Pran's fine, Sean.
Pran,
Pran's
perfect.
fine.
Hey, welcome. Thank you very much for doing this. I know it's with the time zones, you're all the way on the other side of the world in Australia. It's 7, 8 o'clock in the morning, 6 o'clock in the morning, something like that.
8 o'clock. It's all good. It's all
Okay,
good, Sean.
wonderful. Well, thank you. For you folks on YouTube, if you want to catch up the full thing, head it over to MeterX. You sign up for free. You can jump on the live stream. First of all, welcome and thanks for doing this. You are, well, I'll tell you what, let me let you introduce yourself and let folks know what you do. I'm very interested. I've got some great stuff I'd like to ask you about. So tell us a little bit about your background, if you don't mind.
No problem, Sean. So I'm a gastroenterologist and hepatologist. I've now been in practice as a doctor for approaching 20 years now, Sean. But as a gastroenterologist for the last 10 or so. Gastroenterology is the specialty of the human gut, as you know, and our field encompasses hepatology as well, which is a specialty of the liver. So I've been in practice for a while, as I've said, and just it's been really disheartening, I think, to watch this chronic disease model, as you've eloquently put it many times, just sort of lumber on without a view to preventative care. So, just in the last few years, motivated by people such as yourself, and hats off to what you've done in terms of leading the way in these type of nutritional movements. It's been a fun way to practice for me, applying nutrition to people. And it's interesting, how many people prefer this approach as opposed to the chronic disease or the heavily medicated model. So the interesting thing about the gut is, I think that's where the damage is coming from. As we've said, we live in a pretty confusing food environment, and the significant damage that we're incurring to our system through food, and the gut's the primary site of where this damage is occurring from. So it's been a very relevant way for me to practice in a low carb method. And my practice continues to evolve and change as I feel that we're all learning in this space. And I try and stay humble, read, and keep an open mind. But it's a little bit about myself, Sean.
Yeah, thank you. And thank you for the kind words. I'm out there just trying to beat the drum and trying to see if we can kick up the dust and see what happens. The interesting thing, and I agree with you. There's we still think of the gut as kind of this great unknown because there's been a lot of obviously research in the microbiome. People are starting to see how the gut interacts with the rest of our physiologic systems, but that's not news to you. But we have I think there is a lot of misinformation out there. One of the things, there's so many pathways we can go down with this. When we talk about, when you talk about hepatology, study of the liver, you're talking, gallbladder disease, the biliary tree, cirrhosis, all those types of things that we see that are common. Talk about the prevalence of gastrointestinal disease. I looked this up the other day just because I wasn't sure, but it is a huge number of, I know the American stats, but I mean, worldwide, what is the prevalence we're looking at, the people that suffer from either IBS or IBD or, dyspepsia, or GERD, or, cholelithiasis or cholestasis or cirrhosis or, hepatitis or NASH or non-FLD. What is the prevalence of all this stuff? How much are we seeing in the general populations these days?
Great question, Sean. I mean, just to touch on one of them, fatty liver disease or non-alcoholic fatty liver steatohepatitis. This is widespread now to a point where, at primary care level, if an ultrasound's done for slightly deranged liver tests, finding a fatty liver is almost considered the norm. And very little is done to pursue it. I think the patients get a bit of advice, the usual standard diet and exercise, which kind of implies calorie restrict and and do as much as you can physically, with very little guidance on how to do it. But fatty liver is prevalent, and in the elderly population, I suspect most people have it. Not just fatty liver, fatty pancreas, and it all kind of goes together with that whole visceral adiposity type phenotype. But we're now starting to see it in younger and younger patients. Like you could see a slim 17 or a 16-year-old, but because of their consumption of high fructose corn syrup and these refined carbohydrates are so high, they're full of liver-based fat or triglyceride, which is concerning because, like in terms of the statistics, that they predict steatohepatitis will become the #1 cause of cirrhosis in the next 2 decades, overtaking viral hepatitis and alcohol-based cirrhosis as to become the #1 cause. And it's terribly sad because I work in the public system here in Australia, and we see people who are cirrhotic from this more and more. It is not a benign finding, and I don't think we should be considering it such at a primary care level. And
yeah, no, I think, the fact that it has become so common, which is just incredible to me, and people sort of dismiss it as you say, they're starting to normalize fatty liver. But just for the people who don't know, I mean, what does that predict? I mean, what does a sort of prognosis look like for someone with fatty liver if left untreated?
Sure, I think fatty liver is one of the early signs of evolving hyperinsulinemia and insulin resistance. Shawn, I think we're essentially starting to pack a organ system which stores energy or glycogen full of fat, and that is a terrible thing to occur, because as the liver becomes more insulin resistant, then other sites become the storage points for this ingested carbohydrate. So I think fatty liver is one of the early signs of metabolic syndrome, and one that should be dealt with very early. It tends to predict a very poor prognosis, because if one has fatty liver at a younger age, this increases your risk most certainly of other metabolic conditions such as diabetes, such as obesity. Often the two coexist anyway, but then the other conditions such as gout and we could rattle off about 50 of these conditions, chronic disease type things, but it tends to predict a very, very poor prognosis longer term. Whilst benign initially, or may seem benign initially as there's no symptoms from it, the damage is significant. So look, I think it should be something that we're dealing with very quickly and very early, especially in our younger patients.
Let's because there's so many other topics. I know these people want to get to IBD. There's some folks that are in the audience that I know that suffer from that. I want to talk about that. But the etiology of, you kind of touched on that. I mean, we know how to make, foie gras. I mean, we know how we make geese, give them fatty liver. We feed them a bunch of grain and fill them up and load them up with that, and that clearly causes their liver fat. There's been, a lot of debate about what is the cause of fatty liver. I mean, the plant-based folks will say it's because of saturated fat. There's other people who say that it's carbohydrate or perhaps fructose metabolism. What is, as a hepatologist, is there anything we can hang their hat on? Is it just excess of anything? How do we get fatty liver?
I suspect it is, Shawn. I tend not to get too tribal about these things. Like, there's a lot of blame games being thrown around. I think essentially we live in this environment where we're all relatively sedentary in comparison to how we've evolved to be. We're an active beast, and we are clearly no longer that. And I think it is an excess of energy that we're storing in there. I think saturated fat in high enough levels will also cause excess adiposity, and that may not go down very well in some of the low carb circles. But whilst it's more difficult to overeat that type of saturated fat, it in high enough doses, it can most certainly still cause liver accumulation. It is eventually stored as triglyceride. But I think the real damage, Shawn, is really coming from these refined, easy to access energies, which is basically in this form of sodas and these fruit-based juices. I think these are the major issues. And in addition, I think people fail to take into account that sucrose, our very own table sugar, contains 50% fructose. So we're continually assaulted with this fructose load, which may not necessarily, I mean, people seem to think that fructose is fruit, and whilst that's true, fruit is more heavily populated with fructose as the sugar, but really we're being assaulted at all levels. Even a chocolate bar, which contains sucrose, still contains fructose. So it's a constant supply of fructose, which is a very lipogenic sugar. Whilst it may not push up the insulin as high, it converts to fat very quickly. That's the mechanism behind the way humans with our primate rasburicase deficiencies or inactivations store fructose as fat to prepare for a upcoming winter. But of course, as you've pointed out before, winter or famine never really comes. So it's this constant storage, and the liver just gets completely packed out, which is the start, I think, of metabolic syndrome or hyperinsulinemia.
Yeah, I think that's a message. I think, we have this oversupply of energy, and one of the reasons we do is because we have this hyper concentrated, refined energy sources, whether it's refined carbohydrates, whether it's refined fats, or even perhaps even the form of refined proteins, where we have these protein isolates. I mean, we just have refined, high energy, high, easily assimilatable foods that we used to not have access to, and it's very easy to overeat them in excess. Somebody's asking about diagnosis of this. I mean, obviously imaging is going to be probably, unless you do biopsy, which is not convenient for most people. What's the go-to way, most reliable way to biopsy? Can we rely on things like a fatty liver index, which is lab tests, or how do you like to diagnose this, and what ways can we look at that?
Yeah, multiple ways, Shawn. Multiple ways. I think, the assumption that just because someone's lean, they don't have fatty liver is one that's incorrect. I think, as I pointed out before, you can have lean patients with quite severe fatty liver. I think the easiest modality is probably a liver function test, which is a blood test. Often people with enough infiltration of the liver with their fat will show signs of some hepatotoxicity. Primarily, it is the ALT, which is one of the enzymes that make up a liver panel that generally goes up. It's very sensitive to liver damage. So I think that's probably the most cost-effective method of doing it. And I think it's worthwhile doing an ultrasound at the same time if there's high index of suspicion. And ultrasound now tends to be quite sensitive for liver-based fat. So I think the combination of a blood test and a liver ultrasound is the way to go. There are more fancy ways to establish the diagnosis, but they're probably not applicable to the general population. Liver biopsy is gold standard. However, as you said, it's impractical in most cases.
Yeah, what about a GGT? I know there's something called a fatty liver index where they utilize GGT, triglycerides, waist, and BMI. Is that something you see? And can you have completely stone cold, normal, low ALT and still have fatty liver disease?
Absolutely, and this is the difficulty. This is why I say combine it with an ultrasound. You can have absolutely plumb normal liver tests and still have fatty infiltration. Absolutely, yeah. I think there are probably genetic differences, Shawn, and a lot of the research seems to indicate this, and I've seen it clinically as well. There are entire families that I've seen where they develop fatty liver-based cirrhosis very quickly in their 30s and 40s. I've looked after a particular family, a subcontinental group where four of these siblings all died basically of fatty liver-based cirrhosis. So there are clearly genetic factors, and I think the key factor or the key player in all of this is how they metabolize fructose. And I think one size doesn't fit all. I think there are certain people that metabolize fructose extremely poorly. And in fact, there are hereditary conditions where fructose metabolism is impaired, and these people present with fatty liver very quickly. These are genetic conditions that we can test for, but what would be interesting to know is what is one's fructose metabolizing ability for each individual. So it's quite interesting. It can present differently in different people, and I think some of us are just more fructose intolerant than others.
Yeah, and then how dynamic is it? If you get diagnosed with non-alcoholic fatty liver disease, can you get rid of it? What happens when we start getting over to NASH and starting to get some of the scarring? Can that improve? And what has been in your clinical experience the way to do that if that does happen?
Shawn, it's super interesting. I mean, like I've been applying a lot of these low carb methods now with fatty liver disease patients. It resolves pretty quickly. The fatty liver steatohepatitis resolves extremely quickly. I've seen it settle within a month in terms of normalization of the liver function test, and radiologically, I've seen it settle within a couple of months. It really, the method that I give people that are motivated enough to be able to reverse it, I get them to cut down their carbohydrate content significantly, like under 25 grams, or under 50 at the very least. And I tell them to cut out all fructose. I educate them on what fructose is. It's not just your fruit; it's your refined sugars. And if they're motivated enough, that can resolve rapidly. And what they notice with that concurrently is obviously the weight loss that goes with it. As they start burning the triglyceride that's in their liver, which they've been storing as fat, and mobilizing it very quickly. So to me, what I think occurs is they actually mobilize the triglycerol store from their liver quicker than they do from their abdomen. So it actually resolves very rapidly. To answer the second part of your question, what happens when cirrhosis sets in? Well, cirrhosis is scarring, unfortunately, and the liver is an amazing organ. It's got a lot of capacity. I mean, you can see people that drink for years and years that may develop cirrhosis in their 70s and 80s, and it shows you that the liver's pretty resilient. However, when significant scarring sets in, where maybe 70 to 80% of the liver is scarred, you will start getting synthetic compromise, which is the ability of the liver to produce the things that it does, because it's not just an energy storage organ. It does a lot more in terms of producing clotting factors, storing vitamins, mobilizing vitamins. That's a problematic stage once cirrhosis, especially late stage cirrhosis, has kicked in. Interestingly, early stage cirrhosis, or what we call grade A cirrhosis, may not affect daily functioning too much, but the key is to stop it progressing from steatohepatitis, which is a bit of inflammation, to cirrhosis. I think that whole process in most of us takes many years.
Let me shift gears a little bit, and let's just kind of go down the digestive tract a little, start at the bottom and work our way up, maybe, if we can, because I see a lot of people with IBD, inflammatory bowel diseases, which include typically Crohn's and ulcerative colitis, and then also a fair number of people with IBS, which there's a relationship. I know people with IBS tend to have a much higher likelihood of progressing to IBD. They're not exactly the same disease, or maybe I get your input on that. And curiously, we're getting people on these carnivore diets, and they are seeing dramatic improvements with symptoms. They're often able to come off some of these really, disease modulating, immunomodulating drugs. They come off the prednisones, they come off the sulfasalazines, and some of these other standby medications have been using it. Why do you think that is? I mean, we've been told, these people are basically not eating fiber, which has been kind of touted as the miracle that we all need. What are your thoughts on those disorders? Talk about the pathophysiology of that, and why would you speculate these people are getting better and coming off meds?
Sure. I think at its core, Shawn, while it's inflammatory bowel disease, it's a complicated disease, and it's probably multifaceted. I think one of the biggest causes of inflammatory bowel disease is essentially a kind of energy starvation to the gut. Just in particular with ulcerative colitis, which I tend to understand ulcerative colitis a lot better than I understand Crohn's. Crohn's is so much more complicated in many levels, and I'll touch on that a bit later. But with ulcerative colitis, I think the step one is compromise of the mucosal layer, which occurs through essentially what I believe to be an energy starvation of the colonocytes, which then results in the dysbiosis and so forth. So we've got an energy-starved colon, and why is that? And the answer to that question is really quite simple. The colon, the hindgut, relies on fat as a fuel. We need to be supplied with a steady stream of fat, which in the modern day, the only way to do that is basically through fermentation of fiber, which is a very inefficient method of generating this ketone called a butyrate, which is the preferred fuel. We never really tap into our systemic fat stores, which we can do through fasting, which we can do through a low carbohydrate diet, which pushes up your serum ketones, in particular something called beta-hydroxybutyrate, which is a cousin of butyrate. And I think the body utilizes beta-hydroxybutyrate far more efficiently than it does butyrate. Of course, with diets such as the carnivore diet, they are extremely carbohydrate depleted. So there are many stages during the day where these individuals are pushing into ketosis. And what we know about these ketone molecules in gut health is that they are anti-inflammatory. So not only are they a brilliant source of energy for the colonocytes, they are an anti-inflammatory molecule. But by elimination of fiber, does that help? Absolutely. Whilst fiber in itself, I don't necessarily vilify because it's still a modality of producing these ketones. It's just a very inefficient way that we as the greatest primate that ever lived, we do not need that. I think there are better ways to do it. And it's to be able to optimize yourself to be able to produce butyrate, you need an extremely optimized microbiome to be able to utilize the fiber to produce the butyrate. And I don't think we in the West have that. Whereas if you're a Hasda tribesman, perhaps you've got the ability to produce large amounts of butyrate. I don't think we have that in the West. So in a sense, inflammatory bowel disease responds really well to these diets because of this factor. It's quite interesting that there have been many protocols that have been tried and well studied, and in fact, recommended, especially by pediatric gastroenterologists. There's something called a specific carbohydrate diet. I'm not sure. Are you aware of this diet, Sean? It's very interesting, and they essentially do what a lot of people on these carnivore diets do. They cut out the carbohydrates that are the extremely refined ones, and essentially start these people on high protein diets with vegetables. Very simple. And it's been shown to be of great benefit. So that's probably the closest thing that we've got to a large scale trial or recommendation, basically from a medical body. But it shows you there is definitely something to this diet when it comes to inflammatory bowel disease.
Yeah, I find that the perspective about the energy deficit sort of situation very interesting, because you see what happens to people that are chronically malnourished. I mean, their skin starts to ulcerate. I mean, you get sores, and so you're saying basically because the gut is no longer able to get the energy for some reason, we see that on the inside. That's very interesting. And obviously, fat is something we tend to value within this community, and I think that's one of the things that also seems to help with that. Somebody's asking about intestinal permeability. There's a lot of talk around sort of this so-called leaky gut or abnormal, because there's I mean, most people don't realize there's a normal amount of permeability that has to occur. That's normal, and then there's excessive or perhaps not enough. And maybe you can touch on that. Is that a real thing? Is leaky gut just one of these made-up diseases, or are there ways to test that? I mean, I know there's doubly labeled sugar tests and PEG 400s, and is that a real thing?
Yeah, it's a good question, Sean. I mean, it's something that I'm trying to understand, and I'm trying to research this as best I can. I don't think it's a real thing. I know it's a real thing. I think the best term for it is intestinal permeability. I think the leaky gut sort of falls into this. It's commonly thrown around, but you can see it. I mean, you can see it real time. There is something called confocal endomicroscopy, which is basically the application of a microscope to observe the gut via an endoscope. Amazing technology, and you can see the damage that something like a gluten molecule will do to the gut real time. It essentially opens up the tight junctions between the gut layers to allow permeability. As you said, some element of permeability is important, but what we're seeing is excessive levels where we're getting translocation of bacterial species into the peripheral circulation, which then binds end organ systems. And I think this is part of the reason we're seeing these huge surges in autoimmunity now, is we've just got no way to regulate the gut in terms of what's leaking through. The site of damage, I think, is coming from the gut for most of these autoimmune illnesses. So we're essentially translocating bacteria from within the gut to the circulation, where it binds things like joints and sets up these things called molecular mimicry, where it stimulates the immune system, and then we get joint-based issues and gut-based issues from this, or any end organ. But the interesting thing is you can see this real time with confocal endomicroscopy. It's not something that we commonly have access to, but certainly experimentally this is definitely occurring. So it's not just the microbes that tend to translocate. Foods that we've classically eaten, which we should be able to process and keep these toxins of these foods within the gut, we're no longer able to do that. And I think this is why a lot of people with on diets such as a carnivore diet, where they're excluding vegetables and plants, feel better, because essentially they're removing any toxic material, any plant material from this. Not that the plants themselves are necessarily harmful, it's just they no longer have the gut permeability to be able to deal with it. I think once the gut's healed, perhaps some of these low tox plants can be reintroduced for people if they want it, but the first step's healing the gut. And I think this is where this all meat diet's very, very powerful, because it essentially eliminates a lot of these toxins. And I think gluten is a big player in intestinal permeability.
Yeah, that's one of the emphases, at least I've seen, and again, I'm not a GI guy, but I mean, I seem like there's a huge emphasis on immunomodulation. You know, as you know, much of our a huge percentage of our immune system resides within our gut, you know, Peyer's patches and all the,
yeah.
You know, I'm just going back to medical school, remember reading all this stuff, but there's such an emphasis on shutting down the immune system, which obviously has side effects. Why is there not a focus on, you know, energy, healing the gut through, you know, if it's an energy issue or if it's a permeability issue? What are your thoughts on just let's just wipe out everybody's immune system to heal this?
It's a tricky one, Shawn. As you know, being a fellow medical doctor, we're just simply not taught down this pathway, and this is why it's very powerful what you've done in terms of this exploration into diet and nutrition, and it's teaching us a great deal. However, are there large-scale studies which we can apply? Unfortunately not, and this is where it becomes very difficult. How do we apply nutrition in the field of inflammatory bowel disease? And the way I've been applying it personally, I give our inflammatory bowel disease patients the choice, as in, do you want to trial this for 3 months? At least, and see how you go, especially the less severe ones. I mean, some of the life-threatening colitis patients, unfortunately they need to be treated quickly, and some of these patients can die unless we do that. The concept of applying immunomodulation to everyone, that's a house of cards, because generally what tends to occur with these immunomodulators, the bodies will create antibodies against the immunomodulators. So often the efficacy wears off within a few months to a few years, in which case then you move on to another immunomodulator which blocks a different pathway, and it really is a house of cards. Where does it all stop? Where does it all end? And not to mention the immunomodulators, especially the older ones such as methotrexate and Imuran, they can have life-threatening side effects. So it's a tricky one, but I think we need a different model. I think we need to approach this in a different way. But until we can perform large-scale studies, guys like me in practice, it is very difficult to be able to apply it because you don't want to seem like you're practicing outside the guidelines, as you know, Shawn. As a fellow medic, that it's a difficult area to practice that.
Yeah, I certainly agree. So, and one of the things as you know, I'm trying to get some studies going, at least started on this stuff, and thankfully we're making some progress with that regard. There's people talking about. Well, let's talk about gallbladder, I guess, a little bit. I assume your gallbladders fall under your purview. We have a lot of cholelithiasis and cholecystitis. I mean, it seems like the general surgeon can make an entire living off of pulling people's gallbladders out all day long. Why do you think gallbladders? Why are we pulling gallbladders out of people left and right? What's causing that? And then let's talk about if we say that maybe a higher fat approach is maybe preferred. Some people don't tolerate fat, particularly if they've been on a low-fat diet for years. How do you improve that tolerance? Can you improve that tolerance? What has to happen physiologically to make that occur?
Sure. Yeah, cholelithiasis or stones within the gallbladder is an absolute epidemic, and I think it ties in again with metabolic syndrome. I think you've essentially got a reservoir. The gallbladder is a reservoir of bile, and the gallbladder is a beautiful organ. I mean, it regulates the flow of bile into the gut. And what's interesting is when it's removed, you're no longer able to regulate it as well. Often the bile, in response to things like fat, will just flood from the liver into the gut. And bile tends to be pretty potent in its actions as a stimulator of gut motility. It's interesting, like, people on diets such as the carnivore diet still move their bowels, and the mechanism behind that is probably mediated through bile. I think bile is a very potent colonic stimulator, and the problem is once the gallbladder is lost, it's quite interesting. People tend to generally gravitate towards a low-fat diet, and the research shows that post-cholecystectomy or post-gallbladder removal, people tend to become more diabetic frequently. There's an increased incidence of diabetes in those that have had their gallbladders removed. But what's interesting is I think the gallbladder is lost because of excessive carbohydrate consumption. I think to be able to move bile out of the gallbladder properly, you need large amounts of fat in the diet. And I think if you're getting stasis, where the bile's not moving very efficiently, I think you're more at risk of these biliary crystals, which then subsequently become stones. And as you say, the surgeons are very, very quick in removing them if stones are detected. There are probably there are some bodies of research suggesting that we can use medical means in terms of using things like ursodeoxycholic acid to try and improve the flow of bile to try and melt these stones, and some of that is promising. And I've seen certain guidelines that recommend that as first-line therapy. So maybe that's something to look for in the future, where we're using medical therapy to try and dissolve the stones and move it through. But once the gallbladder is lost, it generally is a problem in terms of tolerating fat. It takes you longer for your body to habituate to a higher fat diet. And the part of the reason is you get so much in the way of bile acids that flood the system. It overwhelms the ability of the terminal ileum, which is the last bit of your small intestine that reabsorbs the bile. Once the bile, if it overwhelms the ileum, it dumps into the cecum, and once the bile's in the cecum, you generally get very, very, very rapid contraction, and people tend to get diarrhea with that. So there are ways around it. Again, you can use things like cholestyramine, which are bile salt binders, to try and slow that down while your body's habituating to this low carb method, but it's not the end of the world in terms of if your gallbladder's lost. I think you could still trial low carb diets very, very successfully. Just need to be a bit more patient with it, I think.
Yeah, that's been my experience. We see a lot of people that have had the cholecystectomies, and they adapt. It may take them a little longer, but they generally do well. I think that point that you brought up, the I guess maybe the trade name is Ursodiol. The medication that dissolves the stones. I think there's maybe another one out there I can't remember. But how long does that typically? Because there are people that come into this situation and they've got some stone. They're kind of on that edge, where if they start a higher fat diet, then they get the gallbladder contraction, it's inflamed, and then it dissuades them from doing that, and so they're told to put on a low fat diet, and it just makes a problem. It just pushes it down the road, in my view. And then they, maybe they get a stone that gets trapped in the common bile duct, and then they, as they get all kinds of problems. But
Yeah.
how long, in your experience, or at least maybe what you know from the literature, how long does it take to, say, break up some gallstones and dissolve them? And again, obviously it's going to vary depending on how many they are, how big they are, I suppose. But what would be a time frame you could say, hey, let's try it this way before we take your gallbladder out?
Sure, Sean. What we tend to see as gastroenterologists is when the stone traps within the common bile duct. We very rarely see people with cholelithiasis because generally they're just sent to the surgeons, where the surgeons remove them. So the problem is, once you've had gallstones trapping within the common bile duct, this can be a life-threatening infection. This is called cholangitis. So generally, straight after that, the protocol is, well, if you've got cholelithiasis and cholangitis, the gallbladder must come out. That is the guidelines, unfortunately. So well, I can say honestly that we've never trialed ursodeoxycholic acid, because once we've unclogged the common bile duct, it's sent on to a general surgeon or a upper GI surgeon for a cholecystectomy. I think where it would be really powerful is applying ursodeoxycholic acid in the context of someone who has got asymptomatic cholelithiasis, which is what we see a lot of on these ultrasounds. We've got people with multiple stones in the gallstones. They don't have symptoms yet. The gallbladder is not inflamed yet, and the common bile duct's clear. It'd be powerful in applying that, because beyond that, where they've got inflamed gallbladders, chronic cholecystitis, chronic inflammation around the gallbladder, or common bile duct stones, I think the decision is relatively simple. I think it needs to come out at that point, because of I think it's tipped too far over the edge. But really targeting these asymptomatic patients is where it might be quite powerful.
I got a couple questions in here. People are wanting to know about fasting, extended fasting, intermittent fasting. Do you feel there is a benefit to that? If so, what? How long? Is there a benefit of that above and beyond, like some people are talking about eating basically a meat-based or fat-based diet? What are your thoughts on fasting?
Sean, when I first started off with looking at nutrition, I did a lot of fasting, but I think the longer I do this, and I'm learning as well, and I remain dynamic about a lot of my choices. I'm starting to really embrace just intuitive eating, which is eating food when I'm hungry. And the beauty with a really high protein diet, where a lot of that protein is animal-based, I think you do tend to become a lot more intuitive about your food. You eat when you're hungry. The problem with fasting, Sean, I think, whilst as a younger person who's relatively metabolically fit, I think it's a decent tool to use. But the key is meeting the protein target for the day. I really think that if one is not meeting their protein target, and in particular if they're not doing much in the way of resistance training, there is progressive muscle loss. And I worry about applying fasting in our elderly patients or older patients. I think beyond the fourth or the fifth decade of life, you're more prone to muscle loss unless there's adequate nutrition, and especially if these people are not resistance training. So given that sarcopenia and osteoporosis are such prevalent issues, I tend not to encourage a lot of my older patients to fast. I tend to tell them to prioritize protein, because as you and me both know, Sean, some of the guidelines for maintaining muscle mass in the elderly now suggest a protein intake of 2 grams per kilogram, which is very difficult to get in a 8-hour eating window. If people are doing a 16-8 fast, for instance, to get in 100 grams of protein for an elderly person within an 8-hour window is almost impossible. They can't do it unless they're drinking it as a protein shake or something like that, which often they can't be compliant with. There's no adherence with protein shakes, I've found. So for my elderly patients, I do tend to tell them to eat regularly and prioritize protein at least 3 meals a day. For the younger patients, I think if they can meet their protein target within an eating window of 4, 6, 8 hours, I don't think it matters too much.
Okay, I want to jump into perhaps maybe gastroesophageal reflux disease. Before I do that, there is I think a myth out there, and it's just sort of propagated by sort of a plant-based people that sort of strongly feel that way. We hear that meat will rot in our colon. Now, as somebody who understands probably the gastrointestinal system better than most humans on Earth, I would say, what do you say when somebody say meat rots in your colon? What can we say about that?
I think that's well and truly a myth, Shawn. I think with regards to a protein-based method of digestion, this is termed putrefaction, and I think this is where the myths come from. And we tend to utilize enzymes within our small intestine to absorb quality protein. This is where everything's done. Very little makes it into the colon actually with a high protein diet or animal-based diet, because the colon is the site of digestion of non-absorbable carbohydrates and what we term the FODMAP-based carbohydrates and fiber. So, it's quite interesting. Like people on high protein diets, they claim that they're constipated, and you ask them, "Is it difficult to pass a stool?" No. Why do you think you're constipated? Well, I'm only going once every 3 days or once every 2 days. There is very little waste generated through this method of eating. So, and what's interesting, and I'm sure a lot of your listeners and viewers will know this, a very high protein-based diet with reduction in carbohydrates and fiber, there is no gas. There is very little in the way of bloating. There's very little in the way of flatulence and belching. And the reason for that is you're taking out fermentation as a modality of absorption. There's nothing wrong with fermentation. It's just a very inefficient method of doing it. And for a lot of people, creates symptoms, especially those with sensitivity of their viscera, visceral hypersensitivity, which classically in the past has been labeled irritable bowel and sometimes even treated with antidepressants. Our guidelines suggest using antidepressants to treat visceral hypersensitivity. Well, how about not consuming too much fiber and non-absorbable carbohydrates? That's my approach to it.
Yeah, I want to just elaborate further because, this is, I think, another myth out there. We talk about what is actually constipation. What is the normal range of bowel frequency for bowel movements? There's people that will tell you must have a bowel movement every day or 2 or 3 times a day, or something is drastically wrong with you. What is actual constipation? What is the normal realm of bowel frequency for healthy humans?
Yeah, I can only speak from my clinical experience, Shawn. It's never been defined before, but I think a bowel motion which is not painful and non-distressing to someone is adequate. And for different people, this can be different. I mean, some people may move their bowels once a day. As long as it is a non-painful movement that comes out without distress, that's fine. For some people, it might be once every 3 days or once every 4 days. Again, the same thing applies. If it's not painful, I don't think it's an issue. I think if you apply the mantra that breakfast is the most important meal of the day and you must have cereal, well, you can aim for a bowel motion once or twice or 3 times per day. But again, it's very inefficient. I really do think as a species, Shawn, we've evolved for efficiency. We're not very efficient about the way we're doing things at the moment. And there are some silly mantras that circulate. And, I tend to try and demystify that with my patients. I tell them, well, look, if you're not distressed by a bowel motion, it's not an issue. Lots and lots of systematic reviews, especially in children, that show that fiber is not that effective in terms of alleviating constipation. It actually can distress them even more. But there's a lot of confusing literature out there, but the mantra that fiber is completely essential is somewhat of a myth, I think.
Yeah, let me walk down the pathophysiology of diverticulitis. I know there's associational data that would point to meat as a etiologic agent, or at least it's at least associated. Some people try to use that to pose causation. But when we look at the pathology, if you look at path lines of diverticula or diverticulitis, what in your mind causes diverticulosis and diverticulitis? Do we have any RCTs that say that eating steak's going to cause you to have diverticulitis, or where's the data coming from that people point that to, and what is the actual? I mean, like I said, I've had pathologists saying that they see seeds and vegetable material usually in these diverticula. Yeah. What has been your clinical experience, or do you talk to the pathologist when you see these?
No, I very rarely talk to the pathologist about this, Shawn, but I'll tell you something very interesting. Before our colonoscopies, and we've classically always done this as gastroenterologists, I'm sure it's the same in the States, a week prior to a colonoscopy, we get people off fiber. We put them on a low residue diet, high protein. Why do we do that? Because we want the colonoscopy to be clean when we go in there. In addition to the bowel prep as a cleansing agent, we need the bowel clean. Now, it's really interesting. You do colonoscopies on people and you find leaves and seeds in there, and you go back to them with the photographs and you say, well, when was the last time you ate this? Well, I stopped eating that a week ago, as per your instructions, Pran. And so it shows you this stuff just hangs around the system a lot. I don't think fiber moves very efficiently from a human colon. We lack that muscularity to be able to propel it quickly. With regards to the pathophysiology of diverticulosis, this is super fascinating, but again, I think it falls into the same territory as inflammatory bowel disease. It's energy starvation of the colonocytes. And why do I say that? It's the butyrate concentration on the right side of the colon when you ferment fiber is really quite high. However, it works by direct contact with the colonocytes. However, in the left side of the colon, the butyrate concentration drops off if you're using fermentation as your modality of obtaining it. And this is where we tend to see diverticulosis. As the butyrate concentration drops, the left side of the colon becomes more stenosed, and essentially it's kind of an aging of the left side of the bowel through energy starvation is the proposed mechanism behind it all. And it's quite interesting. It really just links back to energy. This is why we find that people that are fit, metabolically fit, tend to have very little in the way of diverticulosis, which is interesting. And certainly there are some minor genetic factors that come into play, but I describe it as aging, premature aging of the colon. If you're 90 years of age, you'd expect to have a few diverticula, but we're seeing this now in 30 and 40-year-olds, quite significant diverticulosis. And what's interesting is in some people that have enjoyed high fiber diets for all their lives, some of them tend to have the worst diverticulosis, which science can't readily explain.
Yeah, I always point people, there's a study, I think it was done by Peary back maybe 2014, looking at, I think she did 2,000 colonoscopies, and she saw the folks with the highest fiber intake had the highest diverticulosis rate, which I thought was interesting.
Yeah.
I don't know if we have time to touch into colorectal cancer. There are a lot of it's what causes colorectal cancer. I'm sure there's a lot of space, but we always hear about red meat, and, we look at the relative risk. It's, 1.17% according to WHO. It's been sort of re-examined by like Nutrix in 2019 saying, no, there's no data there. What other things have you see when you see people with colorectal cancer? I don't know if obviously if you're doing colonoscopies, you're doing some screening. Are you seeing some commonalities with maybe metabolic syndrome, obesity, and those types of things being more of a indicator, or at least an association, a tighter association with when you find someone with colorectal cancer?
Absolutely, Shawn. Absolutely. As we know, those that tend to enjoy heavier meat diets in the modern world generally tend to have poorer lifestyles. The more educated one is, the less the less they tend to eat meat, because of these guidelines that are just thrown around, that meat's basically the cause of every illness under the sun, despite the fact that we've eaten it for millions of years. What I tend to see with colorectal cancer, it's a very strong link with obesity. In fact, I mean, let's not even consider colorectal cancer. Let's look at polyps, colonic polyps, which are the precursors to colorectal cancer. They are very, very prevalent in those that are overweight. Now, if I was to look at obesity as a risk factor for colorectal cancer, I'd say the risk is somewhere in a margin of 60 to 80%, whereas red meat, based on poor epidemiological studies, has been stated by the World Health Organization as being an 18% risk. So you do the math there, it's sort of, obesity is far bigger a risk factor than red meat ever will be. And we've got to remember, with the World Health Organization, that was processed meat that they looked at. Now, if you're an individual that's eating processed meat, you're generally going to be consuming a lot of burgers and pizzas and these types of foods. I think we've got a real problem with that World Health Organization recommendation. I think it's a very flawed statement that's done more damage than good.
And I know we're coming up on time, but let me ask you your thoughts on probiotics, prebiotics. Are they worthwhile? Are they not useful? If they are useful, in what situations are they useful for? Do they really make a difference long-term on gut flora? What are your thoughts?
I don't think so, Shawn. I think they're very limited in their utility. I don't know what your views are on it. I'd be interested to hear it, actually. But there's actually been publications in our premier journal, which is gastroenterology, that these actually have very limited utility. Maybe there's about 3 or 4 indications, most of it relating to things like pediatric necrotizing enterocolitis and life-threatening Clostridium difficile infections. But us applying probiotics for irritable bowel syndrome or even inflammatory bowel disease, I don't think it works. I don't think it works long term. People might have a placebo effect or maybe some minor changes, but long term, I don't think there's any data. I don't tend to apply it at all. It's a massive industry, of course, multi-billion-dollar industry, and but in terms of its clinical utility, I see very little for it. I think your flora is basically what you select it to be. I think the way you eat basically dictates the type of flora that you've got. So I think that's the way to do it. There's no hard and fast rules to be able to change your flora that way. One of the things that's been tried is fecal transplantation in the setting of inflammatory bowel disease. That's a different story. You're delivering many billions, maybe even trillions of bugs to the system, and that definitely has an impact on changing someone's gut flora. But I think probiotics are an extremely inefficient way of doing it. I think you do it through diet.
Yeah, I don't disagree. I think there's more marketing hype than actual, clinical improvement with that. Let me ask you about reflux. I mean, again, that's another super common one we see, and we slam people with PPIs and we try to suppress their acid. What do you think is, reflux is, it's not the fact that we have stomach acid. In fact, we're supposed to. We're designed that way, but it's in the wrong place. What is the way we should be treating reflux? I see a lot of people going on low-carb diets, meat-based diets. The reflux seems to get better. What is your clinical experience, and what is your thoughts on reflux?
Yeah, reflux is fascinating, Shawn. It's kind of basically it basically encompasses what we've gotten so wrong with our dietary guidelines. Reflux to me is 2 things. It's sarcopenia of the diaphragmatic muscle. I think we are becoming progressively sarcopenic, not just in our peripheral muscles, but also internally. And if the diaphragm becomes sarcopenic or thinned out, it tends to predispose the stomach to push upwards through the diaphragmatic orifice, which basically is what a hiatus hernia is. And hiatus hernias are super common now. So once you've lost the lock mechanism of the diaphragm, you can't hold the acid in as well. The second insult is transient lower esophageal relaxations. What's interesting is if you have fermenting downstream in the gut, that's been shown to increase transient esophageal relaxations upstream, which is why when I tend to see patients with reflux, if you ask them about symptoms of bloating and gas, they tend to get the 2 generally tend to go hand in hand. Now, a low carbohydrate diet, it tends to be very heavy in protein, and I think you're not fermenting as much, so you tend to get less transient esophageal relaxation. So I think the paradigm of blocking acid it's a band-aid solution. And what's interesting, the older we get, the less acidic our stomachs are. So I don't consider reflux as a disease of acid. I consider it as a disease of muscle. Fundamentally, the lower esophageal and the diaphragmatic muscle. So I think PPIs are horribly overused. There are some cases where you need it for things like Barrett's esophagus, and even that, the data is kind of really scant. However, these drugs are now over the counter here in Australia, which is kind of a reflection of where we're heading.
Yeah, I'm going to just get one more question. Probably we should do this again because there's just so much stuff for the gut that I think we could get into. So there's somebody asking about exercise or yoga where you can kind of maybe stimulate to move the gut around somehow. Is there any evidence that there's benefit? I know in general exercise seems to help with GI motility, but can kind of are there, I don't know, exercise practices where you can directly stimulate intestinal motility?
Shawn, I'll go back to one of my initial points, which is that if you're getting into states of ketosis through really intense exercise, I think that's the best thing you can do for the gut. Like a lot of the exercises that you do, I find them inspirational. I love watching your videos. These are heavy exercises where you're going to be tapping into your fat stores, increasing serum beta hydroxybutyrate through your fat adapted tissue, releasing it into the bloodstream quickly. Your colon loves that. Not just the colon, but the brain loves that, and the body will utilize these ketones very nicely. I think there are so many fancy methods, and I think we confuse it, not just diet, but with exercise. I think the simple solution is high intensity exercise or resistance based training where you're really fatiguing muscle and pushing into that fat burning zone. I think that's what's best for the gut. Not just your colonocytes, but the enterocytes, which is your small bowel cells. All of it loves fat as a fuel. So I think this is what we need to do.
Yeah, one more question. I get this question all the time asking about water. Is drinking water with a meal going to somehow decrease the efficiency of your absorption? Is it going to dilute your stomach acid significantly so it's a problem? I mean, can you talk maybe about that, or do you know any data on that?
I don't know any data on that, Shawn. Again, with water, if you're eliminating a lot of these non-absorbable carbohydrates and fiber, I don't know if it's been your experience, but your fluid requirement goes down. I don't think it's necessarily an evolutionary advantage to be drinking 4 to 5 liters of water per day, which is what a lot of people do now for general health. I tend to drink water intuitively, just very similar to the way I eat. And some days it might be under a liter, but I think water is something that we should drink when we're thirsty. I don't know what your thoughts are on that, Shawn. I tend not to drink water with meals.
Yeah, I mean, I've just seen data on how much water it would take to appreciably move the gastric pH. Given the volume and the pH, the whatever we want to say it is 1.5 in the resting state, and it may go up when we've got food in there. That's another question for you. We often hear that based on our human physiology and our anatomy, we have very alkaline, maybe not alkaline, but we don't have very acidic pHs, and therefore we must be herbivores. What is the actual data on normal human gastric pH? Do we know that?
Shawn, of all the creatures in the animal kingdom, we are probably the most hyper-carnivorous creatures that have ever existed. For large portions of human evolution, we were scavengers, and that's kind of where we get our stomach acidity from. Eating high-risk foods such as meat, which are prone to contamination, can be prone to contamination before the advent of refrigeration and things like this. It means to have acidic stomachs is a huge advantage. Not just that, it helps with the breakdown of protein. This is why the elderly tend to require high doses of protein, because their digestive system, in particular their acid, it's reduced. we are hyperacidic stomachs, right up there with vultures and birds of carrion. So this whole concept of acidity and alkalinity, I don't get it, because it's really quite objective. You can measure the gastric pH, and it is 1 to 1.5. The older you get, it can start reaching levels of 4, and once you start proton pump inhibiting people, it can be 5. So how can we efficiently digest or maintain decent immunity with a pH that high, which we're not built for?
Yeah, and just before I let you, my thought on the aging, I think the fact that we lose our ability to produce, HCl is not necessarily directly. I think it's disease. I mean, I think that's just a consequence of some sort of GI disease, in my view. So I don't think it's necessarily you have to age and have higher pH. I think it's just a progression of some kind of disease going on.
Absolutely. I think you need to use it to be able to maintain it. Absolutely. And, a higher protein diet, I think, will keep your stomach sharp. I think it needs to be utilized properly. Whereas, as we know, people just eat very little protein, and these cells age out, and essentially are no longer needed for these people, which is a problem because they'll lose it.
Hey, Pran, this has been wonderful. It's been great I know we've been chatting back and forth on social media. It's good to actually meet you, I guess virtually. Let's do this again sometime, because I feel like there's so much more that in your field that, I mean, it's so broadly encompassing, and so I think there's more we can dig down on. So if you're amenable to doing this, maybe we do this again somewhere down the road, a few months down the road, and kind of keep going with this. But I'm sure everybody in the listening is going to appreciate it. I know this podcast can be very popular when we release it. So thank you once again. I've got to go meet with my neighbor who's a pediatric anesthesiologist, wants to talk to me about research. So I guess he follows me on social media, and I didn't even know. I hadn't even met him yet, but he's coming over here in a few minutes. So I got to go see him.
Brilliant, Shawn. And just before I go, it's been an honor to chat to you, and thank you for everything you've done with this movement. You've taught us all a great deal, and there are a lot of medics and doctors that follow you as well, and keep up all the good work.
Yeah, well, we're all figuring it out. We're all in this together. I know we all want to do the right thing for our patients and the world in general. So thanks again, guys. All right, everybody, appreciate it. We'll see you guys tomorrow. Take care. Bye-bye now. Take care.